Hello and welcome. Today we're diving into a common yet often misunderstood condition affecting women, dysfunctional uterine bleeding or DUB. We'll explore what it is, what causes it, how it's diagnosed and treated, and what you should know to manage this condition effectively. So, what causes DUB? The short answer is hormonal imbalance, but let's elaborate. Dysfunctional uterine bleeding is defined as abnormal uterine bleeding that is not caused by any underlying structural abnormality like fibroids, polyps infection, or pregnancy complications. Most cases involve anovulation, meaning the ovary doesn't release an egg. This leads to a lack of progesterone production after ovulation, which then leads to an imbalance between estrogen and progesterone. Less common causes may include thyroid problems, significant weight changes, stress, and certain medications. Essentially, anything that throws off the delicate hormonal dance within a woman's body can potentially trigger DUB. Let's delve deeper into the how of DUB. In a normal menstrual cycle, estrogen levels rise, thickening the uterine lining, or endometrium. After ovulation, progesterone is produced, which then stabilizes the uterine lining, preparing it for implantation of a fertilized egg. If no egg is released and therefore no progesterone is produced, the endometrium continues to thicken under the influence of estrogen, without the stabilizing effects of progesterone. Eventually, the endometrium becomes so thick that it outgrows its blood supply and sheds in an irregular and often prolonged fashion. The disruption of the normal endometrial shedding process is what leads to the abnormal bleeding patterns seen in DB. Furthermore, the absence of ovulation and regular periods can lead to a build-up of the uterine lining and over time, increase the risk of endometrial hyperplasia. DUB is more prevalent at certain stages of a woman's life. It's commonly observed around the time of menarche, when periods first begin, and again as women approach menopause. In both of these stages, hormonal fluctuations are more erratic and anovulatory cycles are more common. It is difficult to provide precise epidemiological data as DUB is often a diagnosis of exclusion, meaning it's diagnosed after other possible causes of abnormal bleeding are ruled out. Therefore, true incidence and prevalence rates are hard to track accurately. The hallmark of DUB is, of course, abnormal uterine bleeding. This can manifest in various ways: heavier than usual periods, prolonged bleeding that lasts for more than 7 days, frequent periods that occur closer together than 21 days, irregular periods that vary in length, or bleeding between periods. Sometimes, the bleeding can be so heavy that it leads to anemia, causing fatigue, weakness, and shortness of breath. It is crucial to consult a healthcare professional if you experience any of these symptoms. Diagnosing DUB involves a thorough process of exclusion. Your doctor will begin with a detailed medical history and physical exam, including a pelvic exam. Pregnancy tests, blood tests to check hormone levels, thyroid function, and complete blood count to check for anemia are typically performed. Imaging studies like transvaginal ultrasound may be used to assess the uterus and ovaries and rule out structural abnormalities like fibroids or polyps. An endometrial biopsy, where a small sample of the uterine lining is taken, may be recommended to rule out hyperplasia or cancer, especially in women over 35 or those with risk factors. While the underlying cause, hormonal imbalance due to anovulation, remains the same, DUB can be categorized based on the pattern of bleeding. These include menorrhagia, excessively heavy and prolonged menstrual periods, metra leading between periods, menometrorrhagia, prolonged or excessive bleeding occurring at irregular intervals, and oligomenorrhea, infrequent periods. The specific type of bleeding pattern helps guide management strategies. The treatment for DUB aims to control bleeding and address the underlying hormonal imbalance. For mild cases, observation may be sufficient. For more significant bleeding, medical management is often the first line of treatment. This may include hormonal birth control pills, which help regulate the menstrual cycle and reduce bleeding. Progesterone therapy, either oral or via an IUD, can also be used to stabilize the uterine lining. Nonsteroidal anti-inflammatory drugs, or NSAIDs, can help reduce pain and bleeding. In severe cases where medical management fails, surgical options like endometrial ablation, where the lining of the uterus is destroyed, or hysterectomy, the removal of the uterus, may be considered. Iron supplements may be prescribed to address anemia. Preventing DUB is not always possible, especially when hormonal imbalances are a natural part of life stages like puberty or perimenopause. However, maintaining a healthy lifestyle, including a balanced diet, regular exercise, and stress management, can contribute to hormonal balance. Regular check-ups with your doctor help detect and address any hormonal issues early on. The prognosis for DUB is generally good with appropriate management. In many cases, hormonal therapy can effectively control bleeding and regulate the menstrual cycle. Recent research is focused on developing more targeted hormonal therapies and exploring the role of specific genes in the development of DUB. Minimally invasive surgical techniques like hysteroscopic endometrial ablation are also becoming more common, offering effective and less invasive treatment options for women with severe bleeding. Remember to consult with your healthcare provider for personalized advice and treatment options.